So next we're going to move on and welcome Natalie Creary, who is Programme Delivery Director of Black Thrive, which is a partnership between the statutory and voluntary sectors working collaboratively in the borough of Lambeth to reduce health inequalities experienced by African and African Caribbean communities. So welcome, Natalie.
Thank you, Neil. Thank you for the introduction. So I'm going to be sort of sharing some of the reflections that we've had from some of the work that we've done with the system, not necessarily with primary care networks specifically, but I think that some of the lessons and insights that we've sort of learned along the way perhaps would be useful within that context. So, so in terms of Black communities, we generally experience quite significant inequalities in terms of structural inequalities, which therefore then has an impact on our experiences of health and general well-being. And we know that Black people are more likely to live with long-term conditions, and they also develop them earlier than their white counterparts. So we have also found that when it comes to long-term conditions, there are some conditions that seem to get more attention than others. So for example, diabetes and high blood pressure. But when we're thinking about the long-term conditions that are often experienced by Black communities, conditions such as sarcoidosis, sickle cell, lupus often receive less attention, despite often having significant impact on people's daily activities. And one of the things that we've also sort of surfaced is that clinicians can sometimes be ill-informed about the conditions, and also when people are seeking support, that sometimes they're not believed, in particular in conditions that involve pain, such as sickle cell. And this obviously has a significant impact on whether people receive the right care at the right time. And I think, interestingly, despite the healthcare system being more aware of the impact of the social determinants of health, there still seems to be a bit of a preoccupation on health behaviour, individual action or inaction, adherence versus non-adherence. And so it's really important for us to, when we're thinking about the patient, that we're thinking about them as a whole person, and the interactions that, you know, housing, employment, you know, education have an impact on their health. And so in the context of our work, we know that good work is a protective factor. But for Black communities, they experience significant barriers in terms of accessing and sustaining good work. And this has been further exacerbated by the COVID-19 pandemic. So we've received some funding through the Impact of Urban Health, and we've worked to understand the experiences of Black people living with long-term conditions. And we've done that through engaging them through kind of community-based research, and to develop a participatory fund, which has basically resourced 13 organisations, 10 of which are Black-led and 5 are disability-led organisations. And what this process of kind of co-designing has shown us that there is a real value in involving Black people to design interventions through, you know, the lens of our racialised experience. And we've also used this sort of similar sort of design process to design a culturally appropriate peer support and advocacy service. And so one of the things that often has been fed back to us is that actually interventions are often designed not through like what we refer to as the Black lens. And actually that's really important for people to sort of recognise that services are for them, but also that once they are in those services, that they are actually responding to their needs. So in order for us to think about how we do that, it's really important for us to think about representation. So often on boards and decision-making spaces, the communities who are impacted by the challenges that we're trying to address are often not in those spaces. When we're thinking about equalities data, we need to make better use of equalities data, first collecting it, but also then ensuring that we're analysing it and also thinking about it from an intersectional perspective. So really trying to understand how our social identities intersect to shape our outcomes when it comes to health and well-being. And it's really important for us, again, to understand inequalities in the context of structural inequalities and recognise that racism is making us ill. And that's kind of beyond just, oh, you know, people are living in poverty, or that, you know, from racism from a kind of individual level or interpersonal level, that we actually really need to understand how it operates as a whole. There is also something about how we are more critical of the evidence base. So in our work, we also realize that a lot of the evidence base in terms of interventions often don't involve Black people in those studies. So actually it's an evidence base on often largely white populations. So again, it kind of raises the question about to what extent will these interventions be also considering our racialized experience and the impact that that has in terms of whether an intervention is acceptable. And then it's also really important to invest in culturally relevant interventions. And in order to do that, to make connections with and resource Black communities to deliver solutions for themselves.